Shall we go for the next? The next debate will be recent modalities in wound dressing are cost effective. دكتور أحمد جميل ودكتور أحمد الطويل.
Thank you, Professor Nasser and Professor Ahmed Taha, for giving us this opportunity. Recent modalities in wound dressing are cost effective. Diabetes mellitus is a global epidemic that will be expected to reach 5 million over the world by the year of 2030. 25% of diabetic patients will suffer of diabetic foot ulcer. 50% of this ulcer will be infected, and 20% of this infected ulcers will end by amputation. The 5-year mortality rate of amputated patient will reach 46% over 5 years. And all we know, the burden of treating a diabetic foot ulcer on the socioeconomic level. But to reach a good limb salvage rate, we have to adopt the policy of multidisciplinary policy. 58% of complications of diabetic foot ulcers could be prevented through adopting the multidisciplinary team policy. As all we know, any wound will pass through a hemostatic phase, inflammatory phase, proliferative phase, and remodeling phase, and any obstacle that delay this wound healing will turn out this wound into a chronic one. And now, what the chronic wound? It is any wound that have less than 15% surface area reduction on weekly basis, or approximately 50% reduction at 1 month.
Thank you, Dr. Ahmed. Regarding how basic principles of wound management and dealing with wounds, we have to ensure that the wound bed is well vascularized and free of devitalized tissue and clear of infection and moist. And regarding the wound dressings used, they have to provide us with eliminating dead space and controlling exudates and preventing bacterial overgrowth and ensuring proper fluid balance, and to be cost efficient and manageable for the patient and or nursing staff. And the process of dealing with wounds starts with debridement, moving through irrigation and surgical debridement, and enzymatic and biological, and using pack and topical therapies that may be in the form of antiseptic and antimicrobial agents that may be iodine-based or sulfur-based or honey or growth factors that we do not use. And we have to know that when suitable dressing is applied to a wound and changed appropriately, the dressing can arguably have a significant impact on the speed of wound healing and the wound strength and function of the repaired skin and cosmetic appearance of the resulting scar. But no single dressing is perfect for all wounds. Rather, a clinician should evaluate individual wounds and choose the best dressing on a case-by-case basis, considering the importance of moist wound healing and balanced moisture to the wound, leaving the wound not too moist, not too dry. Using the common dressings that may be in the form of films or foams or alginates or hydrocolloids or hydrogels, and aiming to achieve wound closure in the either primary or delayed primary or secondary intention, which is commonly in diabetic foot and post-surgical debridement, that may be assisted by negative pressure wound therapy. And finally, when wound bed is totally granulated, that coverage is needed either by spread thickness grafts or full thickness or skin substitutes or tissue flaps, and that's in collaboration or in cooperation with plastic surgeons. Considering that there is resistant wounds that may need adjunctive therapies in the form of hyperbaric oxygen. And regarding reviewing of the literature, there has been a study, a comparative study by Dr. Kyriakos about comparing the cost and the clinical effectiveness among moist wound healing dressings versus traditional methods in home care patients with pressure ulcers, and the results was favorable to the moist wound healing as a recent modality for wound management regarding the time needed for achieving healing and the cost also. And passing through the guidelines of International Working Group of Diabetic Food dating to 2019, we will find that they strongly recommending that selecting a dressing principally in the basis of exudate control, comfort, and cost, and not using a dressing containing surface antimicrobial as a sole aim for accelerating healing process, and considering the use of systemic hyperbaric oxygen therapy as an adjunctive treatment in non-healing ischemic diabetic foot ulcer despite best standards of care, and suggesting not to use topical oxygen therapy for the primary or adjunctive intervention, and considering the use negative pressure wound therapy to reduce the wound size in addition to best standard care in patients with diabetes and post-operative surgical wounds, but not favorable in case of non-surgical diabetic foot ulcers, and biological dressings like placental derived, they are considering the use of placental derived products, but not growth factors, and considering the use of autologous combined leukocyte and the platelet fibrin, but not using other physically active modalities like ultrasound, electricity, and others. But what we can use for wound dressing in the absence of strong evidence of a clinical or cost effectiveness, healthcare professionals should use wound dressings that best match the clinical appearance and site of the wound as well as patient preference. They are not a substitute for sharp debridement, managing systemic infection, offloading devices, and diabetic control. And aiming for limb salvage must be ambitious and full of courage to deal with such cases, like that cases dealt with at NIDE, where there is necrotizing soft tissue infection affecting the limb, and trying the traditional modalities ended by dryness, and using such moist wound healing with silver ended by granulating wounds and epithelializing, and then covered by spread thickness graft, and the patient regained the full motor power, full mobility and independent motility till now. Like another case in which there is limb-threatening infection. Okay, limb-threatening infection in a chronic kidney disease patient, where there is debridement and use of hyperbaric and the carbon dioxide therapy and endovascular revascularization, and followed by moist wound healing, and then assisted follow-up and assisted patency to achieve such state, and also in such case of young female with a unfavorable outcome following transmetatarsal and the revascularization state. Okay, thank you.
Thank you very